Good evening, and thank you for joining us this evening for the premiere of Keck Stories, a new event to highlight the great work taking place in the clinics, research labs, and classrooms of the Keck School of Medicine of USC. I'm Betsy Jaffe from the Department of Development, and happy to be here to represent Keck. Thank you to Kathy Macker, Shelley Conger, and the John J. Hopkins Foundation for hosting our event reception. Your generosity helped provide a warm start to the evening. The Keck School of Medicine of USC is a leader in innovative education, visionary research, and compassionate clinical care. Located on the University of Southern California's 80-acre health science campus in Boyle Heights, Keck is driving innovation in health and medicine to serve our diverse communities. This evening, we are very proud to have Dr. Stephen Richeimer and Richard Dean Anderson here to discuss pain management. Dr. Stephen Richeimer is a leader in pain management and the director of the USC Pain Center, a multidisciplinary pain management program. As a trusted doctor, researcher, and author, Dr. Richeimer has pioneered innovative and effective solutions for chronic pain sufferers, including effective alternatives to opioids. Dr. Richeimer's triple board certifications provide him with unique qualifications to assess issues related to pain and suffering, pain management, and pain medications. Richard Dean Anderson is known to many of you for his role as MacGyver, running for 7 seasons and 139 episodes. MacGyver is so popular, it's practically a verb. Mr. Anderson has also portrayed beloved characters on General Hospital and Stargate, as well as many television films. Mr. Anderson has helped several environmental organizations around the world, as well as Make-A-Wish Foundation and the Boys and Girls Club, though our favorite philanthropy of his is the USC Pain Center. Please help me give a warm welcome to Richard Dean Anderson and Dr. Stephen Richeimer.
Good man. Thank you all for coming. This is, it doesn't seem like there's, you can turn on the news today and without hearing something about the opioid crisis. And, well, first, let me start off by saying why I'm here, because to be in the presence of this man is an honor for me. I'm here to learn as much as you are. I'm here because I'm a patient of Dr. Richeimer's for I don't know how many years, many years. And when I came to him, I was kind of in some trouble. My life as a child and as an older child, and now as an old child, I was very active, and I had not a career in athletics, but I was very athletic. And most of the sports that I was involved in, were compression-type sports or collision-type sports. So I've sustained all kinds of injuries. I have a list, if you want to see it. I don't know if you've heard this.
Probably not.
Let's see, as far as broken bones, 3 arms, 4 knees, 1 ankle, 4 foot surgeries, a variety of fingers, 1 broken nose, 2 concussions, and a partridge in a pear. No, and I had a back surgery was the most severe one, which is what ultimately brought me to Dr. Richeimer. Prior to being introduced to him, I was desperate to find a way of, because the older I got, the more frustrating it was not to be able to do the things that I did, in part because I was in so much pain. And I lost relationships, because staring across a table from someone and all you're thinking about is how bad your knees or back, whatever, are throbbing. So I was prescribed by a number of doctors before I met Dr. Richeimer, and they were opioid-laced drugs, medications. And I knew I was overdoing it. I just knew it, but there was no solution. So fast forward, the doctor I was seeing at the time, psychologist actually, brought me downtown to the Keck Center, and I met Dr. Richeimer. And I'm not going to say I'm all better, but I'm much better now that I've met him and on a much straighter course. So it's an honor to be here.
Thank you.
So I don't know about you, but I'd like to keep this as informal as possible. Keep in mind that you'll be asked to ask some questions at the end if you want to. I'd hold the questions until later on. It's not be that informal, okay? So I guess we should talk about pain, huh?
Good idea.
Like to do that? Can you just generally tell us how big the problem is? I mean, what the magnitude of the situation?
Well, part of the magnitude, I think, is reflected in just the news. Right? You can't hear or watch or see anything on the news without hearing about the opioid crisis. And maybe later we'll talk a little bit about how we got there, but part of how we got there is how big a pain problem there is in this country and in the world. Studies have looked at it, and 100 million Americans, and there's only about 340 million Americans. So 100 million Americans have had severe pain, and 25 million have significant pain on a daily basis, what they call severe pain. So it's a huge public health problem. And when we think of pain, it's not just a word, but it's something that intrudes throughout people's lives. So it affects their relationships, it affects their ability to work, it affects every aspect of their being. And so now we're seeing how little attention has been paid, and that's part of the reason we're in the mess we're in now.
The opioids are a big, that's been used pretty heavily throughout the years, as I recall reading and my experience. But so how bad is that, the opioid problem?
So to give you an idea of just a way to think about this, if you imagine that 2 737 jetliners were to crash every week and everybody on board were to pass away, that would be approximately the number of deaths from opioids in this country. And what would happen? What would happen if that was happening in the airwaves? Right? You can be sure that the FAA would just shut down all air transport until they solved the problem. And yet, in the United States, we haven't done that yet. We haven't devoted that kind of energy, that kind of effort to figuring out what to do about chronic pain. And therefore, opioids in many situations are still necessary, and maybe later I'll explain why they're not so great besides what you read in the newspaper. But often we don't have other choices because we don't have a lot of developed alternatives. There's some, and I'll share some of that with you today, but there's still lots of need for opioids in spite of the huge problems they cause. So I think what we've seen is a confluence of factors. We've seen really aggressive marketing by pharmaceutical companies that maybe stretched the truth or hid the truth about how addictive opioids were. And now there's some major popular books out about this, so it's easy for people to learn about this. So aggressive marketing combined with a real lack of knowledge in the healthcare world, so doctors take the easy route. And the easy route is give somebody some Vicodin or some Percocet. And so lack of knowledge, aggressive marketing, not really wonderful alternatives led to just prescription after prescription, growth after growth of the use of opioids. and that triggered addiction and overdose. It's interesting. Just this week, I talked to a rehab expert about opioid overdose, and he used, not overdose, addiction. And he used the exact same words as a completely different rehab expert used when I talked to them a year ago. They said, addiction is caused by a hole in the heart. That what we see is a national disease of a hole in the heart. And that opioids are being used by many to fill the hole. So you put all these different factors together and you end up with 2 737s crashing each week. And now it's time to do something about it, but we got to be very, very careful not to throw out the baby with the bathwater, which is a little bit of the tendency of the regulators, is to just clamp down so hard that it makes it very hard for good doctors to still do what they need to do.
Well, the image of the hole in the heart intrigues me. You're not talking physiological hole, right. I understand, but well, how do you approach that? I mean, how do you deal with that? You get, obviously there are ways of different modes of attacking the problems, but can you expound on that hole in the heart? I mean, how are you treating that?
So it's a little bit out of our league, really. First of all, as a pain center, we're not really an addiction center. So these kinds of problems are more dealt with by the rehab centers. And the good rehab centers really, really focus on that. They really try to help people build their relationships with each other. That's why a lot of, I think, addiction treatment is done in a group setting, and where they can support each other and start to build the connections.
It's therapeutic.
It's a therapeutic approach, but personally I have a belief that our society is a society of lack of social connection.
Lonely people.
Yeah. And, we can get into the philosophy of the telephones and the internet and all of that.
I know. I'm seeing spots right now.
So, it's really a separate issue, but I just think it's one more factor that feeds this problem.
And it's big.
It's big.
Huge.
Yeah.
Can you speak to some of the long and short-term effects of dependency?
Yeah. So, what you read about in the papers is all about addiction and overdose, and that's the danger of opioids. And it certainly is a big danger, as we talked about with the, with the crashing 737s. But frankly, when I meet with my patients, and especially, let's say it's a new patient, and they're on a good amount of opioid, and I start talking to them about the fact that this isn't the best treatment and it's time to try to see if we can start switching over. I don't talk about addiction and overdose, almost never, because for most of my patients, thank God, it's not relevant. Most of my patients are using their opioids the way they should. Mm-hmm. Even the new patients often come to me and they tell me, well, I've been on this for 10 years and I've been very stable, I don't misuse it and I'm not addicted and all of those things. And it's true. So for those people, when they read the newspapers, it doesn't relate to them. But what they're missing, and what frankly the media is missing, is why opioids are not good for pain. And there I got to do a little bit of science for you, and that is that nerves talk to each other by chemical messages. So you got a nerve coming from some part of the body heading into the spinal cord, and it'll now talk to the next nerve by releasing chemical, what we call neurotransmitter. It'll activate the next nerve, carry that signal on up to the brain. And once it gets to the brain, that's how we, perceive it. And we've known for a long time that opioids decrease the releasing of chemical from the first nerve, and they decrease the sensitivity of the second nerve. So what we call hyperpolarize. It makes it harder for it to fire. That sounds great. The first nerve and the second nerve, we're turning down pain sensitivity. Sounds great. But in the last 10 years, we've learned a whole other part of the puzzle. And that is what surrounds these nerves are other cells called glial cells. And glial cells are kind of like the immune system of the nervous system. And they regulate the nutrition of the cells. They regulate the biochemistry of the nerve cells. They're the nursery for the nerve cells. And it turns out that opioids don't only latch to the nerve cells, but they latch to the glial cells. And there they activate the glial cells, so the glial cells dump inflammatory chemicals onto the nerve cells and make the nerve cells more reactive to pain, more likely to fire a pain signal. So it's kind of like you're driving down the highway when you're using opioids, a pain patient using opioids, with a foot on the gas and a foot on the brake at the exact same time. Right? The foot on the brake is what we always knew. But the foot on the gas is activating those glial cells and causing the nerve cells to become more and more reactive to pain. So if we can't quite yet, but if we could do the brake without the gas pedal, that would be the perfect drug. Right? So we're not there yet, but we're learning, we're approaching. Some of the alternatives, hopefully we'll have a chance to talk about tonight, are starting to get us in that direction. We're not there yet. We still need the government to recognize we got 2 737s and we need to dump a lot of money into the research world to make some of these things happen.
Jeez. God, you're smart. Well, it sounds kind of, it sounds dangerous, what it sounds like. If that's been the issue, and if it's, why has that been the general, or if it's been so ineffective, or if it's being ineffective, and why is it a typical protocol then? I mean, was it just like what you were saying, it was just easy to take care of?
Well, first of all, this information about the gas pedal side of the equation really hasn't been known until the last 10 years, and it's not even well known to most doctors. And even in the pain world, I would say it's only the last 4 years or so that this information has gotten out. So we still got a long way to go. I would say a lot of pain doctors are not aware of this, and general doctors are certainly not aware of it. And the alternatives that are beginning to come out, they're not aware of. So it's still both the easy answer to give Vicodin, Percocets, morphine, Dilaudid, all of those. It's still the easy answer, and in many doctors' minds, it's the only alternative.
Well, pain's been around a long time. Why is it taking so long? You'd think we'd pay attention to it sooner than now.
Yeah.
But,
if you add heart disease, diabetes, and cancer, the number of patients and the amount of disability caused by pain outstrips them all.
Yeah.
Together. Put those together. Pain outstrips them all. But it hasn't gotten the kind of attention from industry, from government, from private donors, all that. Somehow it's easier to throw dollars at a clear syndrome like, let's say, lung cancer, than it is at something that seems more diffuse like pain.
Is it a political situation?
Partly. partly. I mean, in other words, how the government allocates its money, is a political issue. I wouldn't say it's a Democrat versus Republican issue, but how you get the government to set priorities is a political
So
question.
lobbyists,
Yeah.
for the drug companies primarily.
Not only, I mean, somehow the government reacts to what the public thinks is important. And there have been phases where, heart disease was clearly the number one killer in the government, in the public mind. And so that's where NIH, National Institute of Health, directed its dollars. And that kind of shifted over time to cancer. And that's really been the focus for the last 10, 20 years, And all along has been pain as sort of the stepchild that nobody really pays attention to.
Well, in dealing with those other diseases or injury-laden, I mean, with those diseases comes some pain as well. So that, are they doubling up then? Little pain medication with that cancer drug or whatever?
So, I mean, in the cancer world, very, very little of the research dollars have been focused on pain medicine or palliative medicine. There's a need for it, not only for the patient who is terminal and dying, but even for the patient who's going to recover. They often go through pain during their treatment, pain from the disease. They may have pain afterwards from the treatment. But just like everything else in the pain world, it's gotten a tiny sliver of attention compared to cancer itself.
Yep. Well, what is a typical patient's experience like with dependency? I don't know how to phrase this. What is, I mean, I guess maybe you touched on it when you were talking about the heart again, but what is a patient experiencing when they're coming off, if they've garnered some kind of a dependency on an opioid? What, I guess we're talking about getting off those and into some other treatment. What is a...
Well, there's two halves to that, I think. One half is what do they experience with the efforts to try to come off opioids, and the other is what do they experience just by having chronic pain. And you might speak to part of that also. But, as I alluded to in the beginning, the experience of chronic pain is really overwhelming for most people, and it makes it hard to concentrate. Levels of major depression or major anxiety, diagnosable levels of depression or anxiety exist in 70 to 80% of chronic pain patients. So it just overwhelms people. Typically it overwhelms their coping mechanisms that they've maybe relied on their whole lives. And it may overwhelm the family or their loved ones. It may cause them to lose their work and, just destroy them financially. So there's just huge impact. And I think treating chronic pain patients has to be a multidisciplinary affair. We have to involve the psychologists, the physical therapists, the occupational therapists, as well as the doctors, sometimes nurses and dentists and pharmacists, because it really takes a village, not only a village to raise a child, but a village to treat a chronic pain patient, well and properly. So that's part of it. Then the other half of your question was, what about the patient that is coming off of opioids? What's that like? So there's the physical and the emotional.
Right.
Physically, that's almost the easiest part to deal with, and that's withdrawal symptoms. And if a patient is on any significant dose of opioid for a long time, and you stop suddenly, then they will have withdrawal. That doesn't mean they were addicted, by the way. And so addiction is more of a craving phenomena, that a patient who never was addicted in their lives could still have withdrawal. And so now that's pretty easily handled just by moving very, very slow. If you don't sort of shock the body by trying to get rid of it too fast, then you can keep the withdrawal symptoms very mild.
Just let it know it's coming.
Yeah, and just do it, make a change once a week, once a month, whatever it takes to keep the patient comfortable. The emotional part is often the harder part because in many patients' minds, they feel the brake. They're not aware of the gas pedal. So they feel that the opioids are doing them good, and they're worried about letting go of something that, in their perception, is doing them some good. So that requires education on my part, on my colleagues' part, and hopefully finding alternatives that do better.
Have you come to conclusions on your own, or not on your own, through all your experience and research and stuff?
Some of the alternatives?
Yeah, some of the better ways of approaching it. Personally, because you work for USC, right? Is that a
somewhere it says, right? Keck.
Those Keck folks are everywhere. Well, I guess you may have answered what I was trying to ask. Is that your approach is incorporating all of those elements, not all of them, but many of the elements that you're speaking of tonight? Is that your goal, I guess, is to...
Yeah, as much as we can, is we want to use a team approach with the patients. So we have a full-time psychologist on our team. We have the occupational therapy department has devoted some of their therapists to our patient population. Same with the physical therapy department. So they have therapists now that specialize in chronic pain. And so our patients can be seen by physical therapy, occupational therapy, and pain psychology, and sometimes our pain pharmacist, all at the same time that they're seeing me or one of my colleagues. And that can be so effective in some cases that the patient discovers that they don't need the medicines. The non-pharmaceutical approaches, non-pharmacological approaches are tremendously undervalued, but often highly effective once we get them rolling.
This is just a kind of an offshoot of all that, and maybe we don't need to deal with it now. But what about Eastern medicine? Do you want to say anything about that, or is it?
So we don't have, for instance, acupuncture or some of the other Eastern medicine techniques incorporated into our clinic at USC. But we have lots of patients that are doing it privately, some that we've even helped them find acupuncturists to work with. It's one of the areas where we still need a ton of research. It's clear to me it helps some patients, but not all, and we're not very good at predicting who is going to respond and who isn't. In most cases, it's a fairly safe approach, so I think it's often reasonable for patients to try. But hopefully, as the science advances, one day we'll be able to say this problem is really good with acupuncture, this one, or some other technique, and this one, don't bother.
Have you ever tried it?
I have.
Yeah? Care to share?
So yeah, I had a hamstring injury, probably about 10 years ago, and was doing some physical therapy and was getting impatient, like all my patients get impatient, and wanted to do a little bit more. And so I went to one of the acupuncturists that I've worked with over the years. It's N of 1 trials, meaning a single case study is really not science. but seemed to help. Don't know. Seemed to help.
So it took you that long to go try some Eastern medicine? Or try some acupuncture? Was it puncture or pressure?
Acupuncture, yeah. It was about 10 years ago. Yeah.
Well, if you want to pursue that line of questioning, we can open it up. Do you want to open it up for questions yet?
Maybe we should talk a little bit, because I know that's a big area of questioning, about the pharmaceutical alternatives that are developing to opioids.
Right. Well, that's what I was asking you earlier about what you were, through your research, what you had developed.
So let's go back a second to those glial cells. Those are the cells that surround the nerve cells that opioids latch onto them and activate them, dumping inflammatory chemicals on the nerve cells. So we would love to be able to stop that if we could. And one of the interesting drugs is a drug called naltrexone. Now, naltrexone was created 30, 40 years ago to treat heroin addicts because it blocks the opioid receptors on the nerves. And so if a heroin addict fell off the wagon and started shooting heroin, it wouldn't work because the naltrexone was blocking the way. Typical doses of naltrexone for a heroin addict are 50 milligrams a day. And rumor has it that it started in the alternative medicine circles, but I don't know, that a tenth of that dose, roughly 5 milligrams, given to patients will have less block of those opioid receptors on the nerves and primarily block the opioid receptors on the glial cells, stopping them from releasing their inflammatory chemicals. And there's a couple of good studies that have come out of Stanford. I didn't say that. That actually show that naltrexone works pretty well for fibromyalgia, and we're in the middle of studying it for other neuropathic pain conditions. But we've been using it now since the first study in Stanford came out, so it's probably been at least 10 years, and it's really, really helpful. But even at that dose of a tenth of what you would give a heroin addict, that's enough to block the effects of pain pills. So we kind of felt a little stuck because we couldn't use it on patients who were using pain pills. So just in the last year, a new protocol was developed, which is called ultra-low dose naltrexone. So instead of 50 milligrams for the heroin addict, 5 milligrams for the chronic pain patient, it's 100 micrograms for the chronic pain patient who's taking pain pills. And that will not block, that's not enough to block the opioid receptors on the nerves, but it's enough to partially block the glial cells. So we're seeing some patients respond to that. Clearly not at the same numbers and the same robustness as the 5 milligram dose, but better than nothing. And if the patient is on opioids, this may start the path of helping them to get off. So that's one approach. Another approach that I think many people here have heard about is ketamine. So ketamine, the first time I bring it up to my patients, almost always the first thing they say is, "Isn't that a horse tranquilizer?" And it is, but it's also a human tranquilizer. It's used in the operating room to put people to sleep. And it was noticed, at least 20 years ago, maybe more than that, that people would wake up from ketamine anesthesia with nerve pain temporarily gone. So that started a long research effort to try to figure out what was behind ketamine. And now we know that ketamine blocks a particular receptor on those nerves. Receptors are where the chemicals latch onto the nerves. And it's called the NMDA receptor. And when that receptor, when it's activated, and it's activated by pain, will make nerves more and more sensitive over time. Example, if you hang a picture on the wall and hit your thumb with a hammer, it hurts. But if you come an hour later and you hit it again, it'll hurt twice as much. Okay, because now it's sensitized. Okay, and so repetitive injuries will certainly sensitize the nervous system, but constant pain is perceived by your nervous system as a chronic injury. And so the nerves are getting more and more sensitive and more pain. Ketamine will block those receptors that sensitize the cells, allow those cells to become less sensitive. So little doses of ketamine, interestingly enough, ketamine's been around so long that it's cheap, right? There's no brand ketamine. It's all generic. So therefore, we can't ask, no manufacturer is going to make ketamine pills because they won't make any money at it. So we have to ask our pharmacies to compound it into capsules or creams or whatever we're using. So that's using ketamine as compounded capsules or creams has been very helpful. For severe cases, we actually do IV treatment. And we have a very, very busy IV ketamine program at the Keck Hospital, 8 patients every day, getting IV ketamine, because that high-intensity treatment really allows the nervous cells to start calming down. And then the newest kid on the block is oxytocin. So some of you may have bad memories of oxytocin because it's called Pitocin. Pitocin is the drug that stimulates labor. But it's a natural hormone in the body, and it turns out it's a natural pain reliever. And here too, it has to be compounded, and a lozenge or nasal spray are the ways to get it in the body, almost free of side effects. And it's another useful tool to us. But all of these compounds have one big drawback, and that is insurance companies don't pay for them. So, because since they're not pharmaceutically available, the insurance companies can get away with not paying for it. They basically say it's all experimental and we're not going to pay for it.
Something that's been around for 40 years is experimental?
Yeah, but they say for this use, for this indication. So, and they can get away with it. The FDA has never labeled ketamine for the use of chronic pain, or oxytocin, or naltrexone, any of these. These are old drugs being used in new ways because we're realizing their potential. And since the FDA hasn't labeled them for that purpose, the insurance companies can get away with saying, we're not going to cover it.
Hey.
Yeah.
Get it. With that, you've got my mind out. I shouldn't be thinking so in front of you. You want to say anything else about the treatments?
No, I think that's a good taste of where we currently stand. There's other little, new things developing, but that's a good taste of the main alternatives that at least we're using in the drug world. As I said, as much as possible, we would like to use non-drug alternatives.
But it's a big part of therapy.
It's still a big part of it.
Yeah.
Big part of it, yeah. Ideally, combined with the pain psychology, the physical therapist, the occupational therapist, etc.
I have my swimming pool.
Yep. Yeah, a big part of what the physical therapists do is teach people what they can do on their own. Because you're only going to be in physical therapy X number of sessions, but we need you as a patient to be doing this long term. Okay, are we at a question point?
Yeah, we're going to open it up to the audience. If that's
Okay, that would be great.
I might start with a quick question myself.
Okay.
Dr. Richeimer, I've heard you talk a little bit more on the non-pharmaceutical approaches. Would you mind just taking a minute to elaborate on that? Because I heard you mention that in our discussion prior to the event. And you started to talk about the non-pharmaceutical approaches, and I thought you might want to just elaborate on that if you want to, or no?
Well, as I mentioned, at least in our clinic, what we focus on is pain psychology, and maybe one thing to focus on there is a misconception that many patients have. Because with the vast majority of my patients, I bring up the issue that I think it would be helpful to be working with our pain psychologist. And I can't tell you how often the patient says, but the pain is not just in my head. And I say, I know that. This is a tool for treating pain everywhere in your body. We know athletes can tell us that they can be in an injury state in the middle of a game and not feel the pain. Right? And that is a mind over body event. And if we could harness that completely, we would have great control over our pain. So we can't do that completely, but we can do it partially with training. The other side of the coin is stress will make almost every chronic condition worse. It'll make your headaches worse, your heart disease worse, your ulcers worse, your risk of stroke, everything will be worse with stress. And chronic pain is right up there at the top of the list. It'll be worse with stress. So if we can teach mind over body techniques and stress reduction techniques, that alone would make patients a lot better. Comment about the physical therapy. Somebody hurts themselves. What's the first thing they do? They stop moving the hurt part. They may stop moving altogether and just go to bed. It's absolutely the worst thing they can do. If I had all of you go to bed and say, stay in bed for 2 weeks, you would say, thanks for the vacation, but at the end of the 2 weeks, you would hate me, right? Because you would be hurting. Our body has to be moved. And so physical therapists will help patients achieve that in spite of their pain and get them on the path to recovery.
Or the term fight through the pain.
Yeah, well, I think it probably comes from the sports world. But, but the fight through the pain is good and bad. We want people to keep moving, but they have to learn to do it right so they don't injure themselves. It is very, very possible, probably lots of people in the room have had the experience that they have an injury or they have a chronic pain condition, and they fight through the pain, and then for 3 days they are knocked out, right? Because they flared things up. So we don't want to do that. So we want to find that sweet spot where we're not making things worse, but we're helping them get better. We're keeping them. So again, that's the science of physical therapy.
Yeah.
Awesome. All right, we'll take some questions.
The front?
I'm going to pass it over to you.
Do you have any experience with the use of stem cells to actually kill the source of the pain and heal it?
So we don't have much experience in our pain clinic. The microphone is getting returned to you. It's mostly right now, at least at USC, being used by the orthopedic department. Because that's where the best evidence is right now, is if you have an orthopedic injury, a tendon tear, a ligament tear, a damaged joint, there is growing, I would still say not great evidence, but growing evidence that stem cells and PRP have a role. Probably the first place in the pain world that we're going to see it reach use is treating spine pain, particularly joint pain in the spine, what we call facet problems in the spine, arthritis of the spine, etc. But it's just starting. It's not, I mean, it's definitely research, and no insurance would pay for it at this point. But in another 5 years, we might be there.
Next question.
Yes, in the front here, there was a question.
You got the memo on the top. We match. Thank you for hosting this panel. I've actually been wanting to speak with both of you for some time, so I was thrilled to see both of your names on here. My name is Lauren. I have CRPS, which is complex regional pain syndrome, for those of you who don't know, and you're a very popular name in that world. So it's a two-part question. One is touching on what Mr. Anderson was talking about with alternative sources of medicine, how you feel about CBD and THC, things like that, and noradrenate. And then the second part of my question is, as a person with CRPS, I've spent many nights in the emergency room, and I know a lot of other people who have for the same reasons. And there seems to be a stigma about going in, and when you explain that you have chronic pain, they tend to think you're seeking opioids. And I've had the experience, and I know a lot of other people who have, where we say, nope, not looking for opioids, just need some relief or to get through this flare. How do we, and I've been working with some local hospitals on this, but I'm trying to find the best possible way to explain to first responders, how do we affect that change within the medical community to not just throw opioids at the problem, at the symptoms, and actually address the underlying problem and get the people in chronic pain the help that they need in that situation in emergency rooms, like perhaps ketamine. I know it's helpful in emergency room situations instead of opioids. So how do you feel about alternative medicine, and also how do we make that more available to pain patients in emergency situations?
So you're getting on to one of my favorite topics, which is education, right? And I mean, that's why, for the last 18 years of my career, I've been in a university. And that's what we're trying to achieve. Is we've started some of you may have seen it outside, an online master's degree in pain medicine for any clinician, nurse, doctor, pharmacist, any clinician, or a certificate program. And we're hoping to create a ripple effect, that our students will go and train others and teach others, and maybe other programs will open up that will do things like this, because the one thing that's really clear from the government studies of pain in America is how much lack of knowledge there is in the clinical world. And so we got to change that. One nice thing that addresses specifically what you were saying is 2 years ago, separate from online programs, there's a thing called pain fellowships. Pain fellowships is a way to train doctors who want to specialize in pain. But it doesn't address nurses, dentists, pharmacists, physical therapists, psychologists, which is why we have another kind of program. Until 2 years ago, the fellowships were open to psychiatrists, neurologists, physiatrists, which are physical medicine doctors, and anesthesiologists. 2 years ago, emergency medicine joined. This year, one of our fellows is an emergency medicine doctor. So I think we're going to see over the next few years that emergency medicine is going to get more sophisticated about this and realize, for instance, just like you said, in the ER setting, ketamine, I think, has great potential. More and more ERs will not give opioids, but they need to do something, and ketamine will often be effective and won't have the harmful effects of the opioids. So I think that's coming. Regarding alternative medicine, we just need a boatload of research. We don't have it. We know very little about how effective and for what are these alternative techniques. So we need that. NIH created a separate institute to study alternative medicine techniques. So I think there's some growing focus on that, but it's still a tiny sliver of the research budget.
What are you talking about in alternatives? Like,
Oh, I didn't address that.
right.
And then also neridronate.
Okay, so neridronate is not truly alternative. It's just what it is a bisphosphonate medicine. Bisphosphonates are the class of drugs that are used to treat osteoporosis. And it turns out that that class of drugs can be fairly effective for some neuropathic pain, particularly CRPS, complex regional pain syndrome, particularly early CRPS, in the first year, maybe in the first 2 years. This particular bisphosphonate is not available yet in the United States. It's being studied in Europe, mostly in Italy. There are some American trials of it. Personally, I don't believe it's any more effective than some of the IV bisphosphonates that we have here. I think it's going to turn out to be about the same, which is useful. It's not the magic bullet, but it's useful, especially in early CRPS. A minute about CBD and THC. The studies are very mixed. CBD and THC are components of marijuana. CBD is a component that is not psychoactive, meaning it does not give people a high. THC is a component that does give people a high. We think that compounds that are a mixture of CBD and THC, stronger in the CBD, are having some potential in the pain world, but we really don't know because the studies really are coming back mixed. Some are showing efficacy, and some are not. Lots of my patients try it, and I would say maybe 1 out of 5 stick with it, finding it useful enough to continue. Other questions?
Thank you. Hi, Dr. Richeimer. I just wanted to say publicly that I am one of Dr. Richheimer's grateful chronic pain patients and that this man saved my life. That's not an exaggeration, so thank you. Secondly, as a donor to your program, I wanted to follow up on your master's degree and certificate programs and wonder how, in a philanthropic fashion, we might support those programs. Thank you.
What a great question. So, I think well, let me back up. The problem of lack of education in the pain world is not limited to the United States. It's a worldwide problem. And as I mentioned, it's not limited to doctors, but it's throughout the healthcare clinical professions. And so our educational program is simply out of reach financially to many, many different clinicians in America and internationally. And so one of the things I would like to be able to do is offer scholarships. Offer scholarships to qualified clinicians who have a desire to learn something about pain, and then hopefully will take that knowledge and start teaching others. And so that's kind of the dream that I'm looking for right now is turning towards philanthropy to see if we can put together a scholarship program to get more education out there.
And are you able to give us a semblance of what those scholarships might cost?
So it depends. A 1-year certificate is roughly $20,000. If a student is going to go for a full master's degree, which is a 3-year program, part-time, so they can still work in their careers. That'll be $60,000. So, as you can see,
I think.
I'm glad you said that.
All right, we have time for one more question because I want to honor our time of 8:30, but I do know that Dr. Richeimer and Richard generously offered to stay for a few minutes after and take some questions less formally, okay? So we'll take one more. Does that sound good to you both?
Sure, that'd be fine.
Where are you pointing? Okay, can you help me out? Thank you.
60,000, that's 1 year for Wiley's College. Jeez.
Like one of your first speakers who said she had CRPS, my wife has CRPS, and I accompany her up to 3 or 4 times a week to your clinic. And she receives the intravenous application of ketamine. Is there any data on the many patients you have had and treated as to how effective that might be? Is that something that you can expect to be in for 1 year, 2, 10 years? And I know there's variability patient to patient, person to person, but what's the general view of you and your colleagues who run this program?
Sure. So we are in the process of collecting and now analyzing data from our own program. So I can't give you our official numbers. I can give you my guesstimates. But there are programs before us, which frankly we patterned ourselves after, that developed this protocol, and they do have data. What we are finding is that ketamine IV fairly intensively, like you're describing, is fairly effective in reducing pain. It's a small number of patients that get cured, but it's a large number, a majority of patients that experience significant improvement. And over months, what can be done is the amount of ketamine, meaning the sessions, gets spaced farther and farther apart. And the Drexel program in Philadelphia, which is really the founder of this treatment, has found that they do not stop. That when they stop entirely, there's too great a chance of relapse. So they have developed a maintenance protocol, which we are largely following, of 2 sessions every 3 months, quite possibly for life, as a way to prevent relapse.
Thank you very much.
Sure.
I want to thank you again for joining us tonight, and I want to thank Richard Dean Anderson and Dr. Stephen Richeimer for launching Keck Stories. Thank you so much. So please join me in thanking them, and I hope to have other events to share with you.